on to the next speaker, which is V.Muthurangu. He's from London, and he has a big experience in right heart catheterization in congenital heart disease. And we are very happy to have you here, Vivek, so that you can show how you work in daily practice with right heart catheterizations in the MR lab.
Thank you. It's a real pleasure to be here. I'm just going to start my slides, and hopefully you'll be able to see them. Can you see my slides, Jörg?
Not yet. We see you. You have to share some.
Okay, I was told I didn't have to. Okay, let me just press the present and 2 seconds. Share screen. Okay, so I hope. Can you see it now?
Yeah, that's good.
Perfect, perfect. Thank you so much. Sorry, apologies for that. So thank you for having me here, and well, maybe good afternoon or good evening or good morning, depending on where you are logging in from. So I'm going to talk about MR-guided right heart catheterization. And the story does start in congenital heart disease, but it really ends with the much bigger population, which is adults with pulmonary hypertension, or at least the risk of pulmonary hypertension. So we all know about X-ray guidance. It's a fantastic way of guiding cardiac catheterization. You get good visualization, particularly of the wires, the devices, the catheter, and maybe less so of the heart. And probably most importantly, and Dara's already sort of touched on this, we have fantastic device compatibility. You know, you can go to your cath lab and you can pretty much pull any device off the wall and you can visualize it, and it's safe to use under X-ray guidance. The issue, of course, and particularly pertinent to children, is radiation. And yes, radiation doses are always coming down. X-ray angiography labs are always becoming better, but there is still radiation, and even a small amount of radiation we need to think about, particularly in children. There's the issue of poor tissue contrast, more of a problem when you're trying to do biopsy than right heart catheterization, but still not an insignificant issue. And finally, it's a two-dimensional, and it's worse than just two-dimensional. It's a projection imaging modality. So you really can't navigate around the heart, particularly when you have complex anatomy. MR fixes many of these things. There's no radiation involved. You get excellent, exquisite soft tissue visualization. Importantly, we'll get onto this, it gives you reference standard measures of function and flow. But of course, there are risks. Obviously, there are risks of the MR scanner, but there are the risks that Dara's already spoken about: heating, incompatibility of devices, the fact that really there are a very limited number of devices that you can use within the MR environment. Nevertheless, it is really, really well aligned to the problem of right heart catheterization and measurement of pulmonary hemodynamics. So why is that? Well, let's just think about pH and pulmonary hypertension. Here we have two lung vasculatures. On the left-hand side, you've got this, very, very branching pulmonary vasculature. On the right side, you've got this pruned pulmonary vasculature of a patient with pulmonary hypertension. Of course, you've got reduced diameter of the small resistance vessels. You've got a loss of vessels, and all of these things increase the PVR and therefore the PA pressure, and therefore, of course, right ventricular afterload. Now, the classical way of assessing PVR is to basically measure pressure and to measure cardiac output. The pressure we can measure invasively, and still, I know Tobias is going to talk about this a little bit in the next talk, but still, if you really want to get reference standard measures of pressure, you need to put a catheter into the PAs. And cardiac output. And, there are a couple of reasonably good ways of measuring cardiac output in the cath lab: thermodilution, the Fick method. But remember, thermodilution doesn't really work if you have shunts and if you have valve regurgitation. The Fick method is better when you have shunts. We use it a lot in congenital heart disease, but it requires a lot of measurements of oxygen saturations, oxygen content. There can be errors that propagate. So You have to measure oxygen consumption, which many people don't even measure, but just estimate. So although the method itself is really robust, it's only robust if you do it well, and most people do it really badly. MR is a really, really accurate way of measuring PA flow or cardiac output. I would actually say that it is the in vivo reference standard for measuring flow. So can't we somehow combine pressure with measurement of flow using MR? Now, you don't need to do MR guided cardiac catheterization to get the benefit of MR. For a long time, we did something we call MR augmented cardiac catheterization. So this is the hybrid lab at Great Ormond Street. And basically, it's two labs separated by some RF shielded and X-ray shielded doors. So I can just take you through this video. These are all children, so they're all under general anesthetic. And so what you can see here is a patient being slid over actually from the MR side to the X-ray side. It takes about a couple of minutes to do that. And they're maintained with on anesthesia throughout that period. So basically what would happen in this sort of MR augmented framework, a catheter would be placed under X-ray. We'd be using a balloon angiographic catheter, which is MR compatible, usually stick it into the wedge position. We then do the transfer over. We then do flow quantification, just using regular sort of out of the box Cartesian free breathing flow, usually in the aorta, PAs, branch PAs. And of course, we've got the catheter in situ. So we are doing simultaneous pulmonary artery measurements. We would then go into the wedge position, and now we can measure PVR. But we're measuring PVR incredibly accurately because we are getting the reference standard way of measuring flow. And then, of course, we do some ventricular assessment. So that gives us a comprehensive assessment of the full physiology of these patients. And certainly in children, we'd repeat that physiology assessment after giving nitric oxide, a vasodilator that we give in all of our children. So augmented catheterization, and certainly what I've just shown you, actually came after MR guided cardiac catheterization. So this is myself, Reza Razavi, who's really one of the sort of pioneers, or if not one of the main pioneers of this technique, and one of my other colleagues, Andrew Taylor. And this is in the hybrid lab at Guy's Hospital in the early 2000s, and Reza's doing an MR guided cardiac catheterization there. And what he's looking at is this. So this is an interactive real-time SSFP sequence. We have a balloon angiographic catheter inside the patient, and all you can actually see is the balloon filled with carbon dioxide or air. So that's all that we can see of the whole catheter. Nevertheless, actually, you can float it into the PAs relatively easily. So this happened over 20 years ago. And one of the things that's been slightly frustrating is only a handful of centers are currently doing right heart catheterization. I think that's changing, and it has been in the last 5 years, but certainly for about 15 years, there was about 5 centers that did it. So that was because there were some problems with this approach. First of all, access is a huge issue. You can see Reza's quite a tall chap, and he's really having to sort of bend over, and it's very, very uncomfortable to have your hand all the way into the bore. Particularly remember, if this is a child, you know, their femoral insertion site is a long way from the outside of the bore. Other issues is that, yes, we have nice soft tissue visualization, but it's quite low resolution, both spatially and temporally. We can only see the catheter tip, and really only as a sort of area of signal loss, which can easily get mixed up with other areas of signal loss in the image. Also, and this at the time, everyone was saying you needed a hybrid lab. So you needed to have an MR and either an adjoining room or have an X-ray set up in the same room. And that's incredibly expensive. And that was a real barrier for people to sort of get into this area. And finally, certainly at the start, it took a long time. Now, albeit these are congenital patients, but doing a right heart catheter that takes, these are only the first 25, that takes 3 hours, That's not optimal. Remember, these patients are under general anesthesia, and the longer the general anesthesia goes on, the higher the risk for the patients, particularly for children. So we needed a slightly different approach, but it was still really useful. It gave you very accurate PVR, particularly when we were vasodilating patients, where it's more difficult to measure oxygen consumption if we're using the Fick method, because we usually give oxygen as a vasodilator. And it's really useful in patients like this. So in this sort of patient, it's really impossible to use classical catheter-based methods to measure PA flow. There's just too much shunting going on. But in MR, you can always measure PA flow. You can measure it whether you do it in the branch pulmonary arteries, in the pulmonary veins. There's always a way of getting QP. And that means it's really, really useful in complex CHD. But if we want to move it to adults, and certainly, people like me really want it to be used routinely in right heart catheterization in adults, we need a different approach. We need a cheaper, more pragmatic, more flexible approach. So my really good friend and colleague, Dan Knight, who was one of my fellows, and so we did a lot of MR cath at Great Ormond Street. When he went on to lead a PH service at the Royal Free Hospital, he said, well, I want to do MR cath. But all he had was a very, very conventional MR scanner. So we really put our thinking caps on to see, well, can we make this work? Can we do MR cath in, the MR scanner that everyone has? So this is a completely conventional MR scanner, 1.5 Tesla. There's a few bits and bobs here that are not in every scanner. So we have a screen. Lots of scanners have screens because they might want to show people videos and things, and particularly pediatric ones. We've got some pressure monitoring. That's quite common in most scanners now. So if you have any form of anesthesia happening, you'll have some sort of monitor that can measure invasive pressures. And so this is MR cath being taking place at the Royal Free Hospital. You see Dan Knight there at the console and Jerry Coughlin actually doing the catheterization. And this was actually a process and a procedure that we found relatively easy to do, even without a lot of additional things. So we don't have optoelectronic headphones. Those are just actually the normal patient headphones that we use so that we can speak to Jerry, because the patient doesn't really need to speak to us. Actually, we've got rid of those now because we can just do hand signals, and that seems to work just fine. Here you can see the catheterization happening. So once again, you can see the little balloon tip. And here probably is the most important bit of this. These are the times for the first 50 patients. So you remember our first graph had sort of right heart caths taking 3 hours in congenital heart disease patients, and these are not congenital heart disease patients. But the time from the catheter insertion site, usually in the femoral, to the actual wedge position was 3 to 4 minutes. So the period of catheterization was about 3 to 4 minutes. Then to do the full MR after that, so is about 25 minutes. So it takes 30 minutes to do catheterization, get all the flows, get all the function. And this is using completely regular out of the box measures. And then our sort of total time was about 1 hour. So that was 1 hour from the patient coming in the department to the patient leaving. That means we can actually do 4 of these in a single morning. So now we've done about, I think, over 500 of these MR caths, because it's very, very, very routine. We do as many MR caths as some places will do normal MRs in a morning. So there were some predictors of actual catheter time. Not everyone took 3 to 4 minutes. Some of that was related to right heart size. So the bigger the right heart size, the more difficult it is. And some of it was to do with RV afterload. And I think this is mainly related to sort of RV hypertrophy. And it's easy for the catheter to get caught in sort of thickened trabeculations. We also had some failures in our first 50. So here are the 3 failures, all quite significant pH. So these are mean PA pressures of over 50 in these patients. Now, in these patients, and we've already heard, there are now guide wires that you can use. So this is the, apologies, that's not playing. So sorry, that's not playing, but that was the NanoFit imaging guide where Dara's already shown you that. It's got 3 passive markers, and that does help. Actually, for our routine right heart cath, we don't use guide wires. We have about the same fail rate. It's probably going down. We've moved from going from the femoral now, from going to the jugular. We have almost no failures, even in severe PH. Some of them take longer, but we have very few failures. But here were the things that are linked to failure. And it's the same sort of things that are linked to the time for catheterization, volumes and pressures. So what we think actually now is that right heart catheter, everyone should be doing right heart catheters in the MR. You don't need anything special. A really conventional MR scanner is all you need. You will need a screen in the room that costs about, I don't know, £10,000. You'll need a pressure monitor. Most of you will have those pressure monitors in your scanner already. And even with completely regular imaging, the stuff that comes with every scanner, you can do a whole procedure in less than an hour. And I think you can do multiple procedures in adults in one MR session. But how are we going to make this better? How are we going to make this quicker? So one of the things that we're very interested in MR, right heart cath, is the physiological assessment. Okay, I actually like to call this catheter augmented MRI because it's the MRI bit that's important, and we also get a pressure. So one of the ways to go from this sort of image, which is cardiac gated, to faster imaging is to go real time. Now, conventional real time doesn't look very nice. It's got low spatial resolution, low temporal resolution, but we've certainly for probably the last 15 years been working on trying to accelerate real time. So here is a real time sequence, which is already quite old, using compressed sensing. It's a spiral sequence. I think it's very difficult to tell these apart, but here they are. So the one on the left is actually a classic breath hold, 10 to 15 seconds per breath hold. The one on the right is real time, each slice acquired in a single heartbeat. So that means that you can acquire the whole of the ventricular stack in 20 seconds rather than 5 or 6 minutes. So that really speeds up your sort of catheterization throughput. The other thing, of course, is flow, but you can do exactly the same thing. So here's some real-time flow, very, very good spatial and temporal resolution, good agreement with our classic Cartesian. This is the most important bit of a PVR scan. So this is the bit that we absolutely want to get right. The big problem was, although we could do function and flow in less than 5 minutes, so that means that if it takes 3 minutes to catheterize and 5 minutes to get the function and flow, maybe you could do the whole thing in 10 minutes. The reconstructions were very, very time consuming. So Jörg's already talked about this. We're really using ML a great deal for this. And this is really to do with image reconstruction. So what we did historically, and we've changed it slightly, is we've taken lots of stored DICOM images. We simulate these real-time acquisitions with all the artifact that we have to get rid of with our computational methods. We stick those into a UNet and we train the network to actually go back to the high quality artifact-free images. So here's just an example. Here's a breath hold. Here's a patient, the same patient obviously scanned with a real-time sequence reconstructed with compressed sensing, which was the previous sort of state-of-the-art method. It's not bad, but it's not brilliant. Here is the same real-time data now reconstructed with machine learning. And you can see a really significant improvement in image quality, but actually also it's much, much quicker to reconstruct. We've actually taken this one step further. And so rather than using MR data to train our models, which is difficult to deploy, it's difficult to share, it's difficult to commercialize, we're now using these videos from YouTube, balloons, cats, dogs, whatever, and actually using those to do the reconstruction. And if you see on the left, the DL natural videos, the one in the middle, is these are prospectively acquired MR data reconstructed with these natural videos, machine learning, and they look really quite good. So what we're also doing with machine learning is we're really leveraging that very, very fast reconstruction. So I said at the start that we have to guide our catheters with real-time imaging, but it has to be interactive. So you have real-time imaging and real-time visualization, which means that actually we've always been a bit bottlenecked. So they always have very relatively low resolution, both spatially and temporally. What we've been doing is taking machine learning. So this is now interactive spiral machine learning real time. And this you can see is at much, much higher spatial and temporal resolution. So now we've got cine quality imaging, but that we can use for guiding MR cath. I suppose in the future, what we would want is something, particularly for in the EP world, where we can look at sort of meshes and we can look at 3D volumetrics. This is an X-ray version, and we're certainly working on that, something like that. So this is a version that we're working on that can give you about 7 or 8 frames per second, but of the whole 3D mesh that's both cardiac and respiratory sort of triggered. We can also use this to do exercise in the scanner. So this is obviously a bike here, and this is real-time function and flow during exercise. This is our real-time machine learning method for ventricular function, but actually in exercise. And I think it's really excellent image quality for exercise in real time. But what we're really interested in is not just real-time assessment, but real-time visualization, but also real-time assessment of physiology. So the method I'm just going to show you now actually takes real-time flow, and then as it's coming through, does the ML reconstruction and segmentation. So what you see here is a screen capture, and this is actually just a normal healthy volunteer exercising in the scanner, and we're actually seeing this in real time. So it's got about a latency of a second. So as the heart rate goes up during the exercise, as the cardiac output goes up during exercise, we're actually seeing things in real time. And that really changes how we think about MR. MR for a long time has been, you get the images, you take the images off, you put it onto your workstation, you do the processing. Now we're moving to something where we can actually see the physiology in real time. I think that's really exciting. And this is our new sort of simple, pragmatic exercise machine for the cath lab. And it's basically just 2 drain pipes. And we've got these weighted socks on, and then we just ramp it up. And this we're using in the cath lab. And really in the cath lab, it's impossible to use one of the bikes. So I think this is a way of doing it, which is safer and easier in the ML cath lab. And in the last couple of minutes, I'm just going to finish by talking about the other big issue with MR cath. And some of it is being removed because of things like wide bore, low field magnets. But I still think there's going to be an issue with access. And one way to get around the problem of access is robots. So here's a robot that we've been developing. This is an MR compatible robot. Doesn't look very scary, or doesn't look like the most exciting robot in the world. But remember, the catheter only has to move backwards and forwards and left and right. And so this robot can do that. But what we've been really excited to do is see if we can make this autonomous. So we have a simulator where we can train agents to do autonomous catheterization with a simulated cath. We can then take that agent back to the robot, and obviously this is all happening still in phantoms, but I can just show you a little video. So this is the robot acting autonomously in a plastic catheter, in a plastic phantom, and you can see it keeps on going up the appendage, the right atrial appendage, and it keeps on rotating around, and it's trying to work out how to not go up the appendage. And you can see now it's done enough rotation so that it can come up. So this is completely autonomous. So this is autonomous catheterization, which is many years away probably, but still really very exciting. So to finish off, so MR right heart cath, I think it's got great advantages. I think that really everyone should be doing it if they can, because I think what we've shown is it can be fast. You can do it in a normal scanner. And for the catheterizers, it liberates the cath lab for more important catheterizations like coronary cath and PCI. So it's quicker, it's better, and even the patients like it because they're always going to have an MR. You might slightly extend the MR, but they get both of their procedures done in one go. I think ML is going to give us better imaging, so allowing us to do that catheterization quicker, but also allowing us to image more physiology. And, finally, there's still an access problem. I see that, vendors are bringing out 100 centimeter bore magnets now. So, maybe less of an issue, but I think this is an area where self-navigation and robots could be really useful. If people are interested, myself and my close collaborator, Dan Knight from the Royal Free, we actually run right heart cath so you can come and actually practically experience right heart cath, and we've had quite a few groups come over, witness us doing some right heart caths. We sort of go through all the practicalities of it. So if you want to come over to the Royal Free, we do a whole day sort of practical for right heart caths. Just email myself or Daniel Knight. We're really happy to have people over. It's completely free. We just want more people to do right heart cath. Thank you very much.
Thank you very much, Vivek. It was a great journey from early days to the future. Very interesting. Thank you very much. I just wanted to ask you at the end, what can we do that more people will do cardiac catheterizations in the MR lab? But you already answered.
I think that I think we historically, I think the community made it look a little harder than it is. And so what we've been trying to do, certainly myself and Dan, have really been to try and show that it's not that difficult, that anyone can do it. You don't need a lot of specialist equipment, a little bit, but not a lot. You can do it in a regular scanner. And that's why we also offer this opportunity for people to come over, because we really want to show people in person that it's not difficult. I mean, we did a live case a couple of years ago at CMR where we did the whole thing in an hour plus some exercise in the cath lab. So what we want to show is that it's not difficult, that you don't need a lot of specialist equipment, and that you can just get started. And that's why, as I said, we're really keen for people to come over. And Tobias, who's going to be speaking next, came over. Marco Goethe came over. Lots of people have been over and now doing MR cath, which is what we want to do.
Sophia, Panos, you have questions?
No.
I think it's exciting. It's exciting that many traditional interventions can be performed in an MRI environment. This is good for both doctors and patients, specifically kids.
Yeah, absolutely.
Maybe more reliable than the ordinary cath. And
yes.
I mean, recently I studied that there are small magnets that can be that they are mobile and can be used for brain evaluation in intensive care units. So that would be ideal if we had very small mobile magnets for the heart. Of course, it's far away at the moment, but small field and mobile magnets. That will be the solution, and also between about the fight between cardiologists and radiologists. Cardiologists will be again independent.
Yeah, so last year in Science, there was a paper from a Hong Kong group with a very, very low field body magnet. They showed cardiac images, and so it was just plugged into the wall. It was in a normal room. So I think you're right.
How it was the heart in the mobile?
This was the heart in a mobile one. This was it's not a product. It was in Science, and it was a research methodology. But it's coming. It's certainly coming.
I'm so happy.
I was very impressed about your ideas that robots can do catheterizations, and in fact there are not so many degrees of freedom how to handle a catheter. You can go inward, outward, rotation, and bending. So these three things can be done by a machine. When do you think you would do that in an animal? You are close.
Yeah, I mean we're along. I mean, we want to get the robot working first, which is a catheterizer controlled robot. So that still is not a product. That's just but once you have a robot, the next thing is to make it autonomous. We would do it in an animal first. We're a long way away from that. But I think as you say, this is a great application for autonomy because there, you know, and actually there's only two things you can do in a balloon angiographic catheter. You can only push it backwards or forwards, or you can only move it left or right. So it's a slightly easier problem for robotics. So, you know, whether it's full autonomy or whether it's helping, I'm not sure how that looks, but it's an exciting area to be in.
I just had the idea that if you have a robot that wants to learn and he is able to do something, he can come to Lausanne and use our simulator. Then he can learn on the simulator.
Absolutely.
And he can see what he's doing.
Absolutely.
Great proposal.
The machine works in a machine. Okay.
May have two short comments here. First, I enjoy, of course, very much your presentation, very much, and especially I enjoy very much your open call for those who like to enjoy and to learn something more to visit your lab. It's very kind. Second, I like to reiterate the same comment and the same question like this morning, which is for us living in different countries in Europe, pivotal, important. Who has the right, apart of radiologists in UK, to run independently, autonomously, even MRI? Because for us, the cardiologists, I am cardiologist, correct? What is your specialty?
Cardiology.
You are a cardiologist.
Yeah. So in the UK, it can be either, and it doesn't have to be combined. So there are lots and lots of centers that are run by cardiologists.
This is one of the main barriers. This is amazingly tough barrier for us, for many countries, to beg in front of the door of radiologists to give you the opportunity for collaboration. It is an amazing, and especially if you are talking about new techniques, new technologies, which need a lot of work in very close proximity. The second is much more philosophical, and this is coming from somebody in Europe, possibly you know me, possibly you don't know me, that I am a synonymous of futuristic and innovative technologies. But as I'm possibly this is the most time that I'm addressing this question, and somebody who knows me will be a little bit surprised by this question. What is the reason why we need robots to perform catheterizations? So what is our next step? We are aiming to become free of charge cardiologists, reimbursed by the country just to enjoy looking at the robots?
So I think it's a very good point. So the robot that we are developing is actually going to be it will be controlled by a catheterizer. So the reason that we are creating the robot is to fix the access issue, which is that we don't want the catheterizers bending down and hurting their backs. So that's a joystick controlled robot. Once you have a robot, then people like me who are interested in machine learning want to see if we can make it autonomous. But that is not why we have created the robot. The robot really, like a surgical robot, is still controlled by a human. It just makes it easier for that human. They don't need the MR scanner. They can be in the control room, comfortable, sitting comfortably and controlling. The autonomy, partly, why do people go up Everest? Because it's there, and it's a little bit the same thing.
Yeah, I got it. I got the message. And again, Sophia, not only Sophia, everybody knows me, not only in Greece, in Europe. I am, as possibly you know, I am in charge for innovation and AI and digital health, deputy editor of the European Heart Journal, etc., etc. So I'm working feverishly up to the 3 o'clock in the morning every day about futuristic solutions. But from time to time, we have to be a little bit more philosophical. To listen from somebody who is number one, for example, basketball player to announce proudly that robots are coming to play for us basketball. It's a philosophical issue, is not? So what the basketball players will do if the robots are playing basketball?
But our mission is to find solution, not to push catheters.
I'm not talking about the knowledge. The knowledge is one-way road. The knowledge is one-way road to go to LLMs, etc. Okay, we are already there. Already there. And 2 days ago here in Athens, I had a big event about and I had actually placed two groups. One very experienced clinicians, and the second group was me plus the ChatGPT-5 to compare the clinical reasoning, which is very important. Clinical reasoning. Clinical reasoning, in my opinion, should be taught, should be given as lessons in all universities nowadays. Clinical reasoning, one by one, the steps to reach to clinical decision. But I hope it's going to be very soon there. But skills, I can recognize how much significant it is for us to create robots with skills. But what is next then for the humanities and others issue, okay?
I don't disagree with you, but what I would say is that maybe it liberates our minds to do other things and liberates our training to be focused on other aspects of the patient journey. But I also don't think robots will take over. I think maybe, most catheterizers, I'm not a catheterizer, but most catheterizers I talk to, they don't really want to do white hot cath. They think it's more, they want to do primary PCIs and CTOs and things like this, or TAVIs. So I suppose we're trying to use robots for things that are easy and that aren't the things that, we're liberating them to do other more complex things that will always need, or certainly in the foreseeable future, always need humans.
Yeah, I'm not so sure, Vivek. I think the more complex things are, the more AI will win. At the end, I think
maybe I'm also being,
and the more difficult ones will be done. But at the end, I think, as you said, you try to do it because it's a challenge. You like challenges. You try to do it, and if it works, you are happy, and then people will use it. I think AI in many aspects in medicine, maybe also robots, they will at the end deliver high quality outputs, and they may deliver that at lower prices. So at the end, why should we use it? And we have to think what we do with our free time that we get. We are not so far away from this. We did just a study here with Meng next to me, and she was also part of that we acquire data automatically, we analyze data automatically. At the end, you get the report with all the ejection fractions and all these things without any human being involved. They are out. And in one study, we looked at how many patients need an ICD. They get sudden cardiac death or malignant arrhythmias. The machine learning algorithm analyzed the data, looked for scar, analyzed the scars. And if you add this scar quantification to the guidelines of the ESC, you have a better discrimination. So this algorithm helps to discriminate, should there be an ICD, yes or no. So it comes very fast. And I think we have to discuss these issues before they are here. Because if they are here, we will use it.
Let's move on, because you are a little bit late.
Yes.
Yeah.
Okay. I think I will introduce the next speaker, which is Tobias Rutz. He's responsible